Good afternoon. My name is Debbie Bucci, and I'm from the Office of National Coordinator. And I'll be moderating a session on, what are we calling this? The Intimate Wearables and Big Data. Those of you who may know me, I cut my teeth on identity management, but my focus at ONC is on patient-centered, consumer-mediated exchange, and that's all kinds of health-related, including wearables and endpoints and things like that. So as we were preparing for this panel, there was such great discussion. So what we're hope to do is have a quick introductions, a little bit of talk from all four of them, and then some dialogue between them for 2 questions, and then we want to open it to the audience. So we do hope this would be interactive. So the first person to my left is Benjamin West, and Benjamin West is the co-founder of the Night Scout project, which is building an open source system to put continuous glucose monitoring information in the cloud. So the next is Adrian Grapper. He, as you know, he wears many hats, but for this, he is the Chief Technology Office of the Patient Privacy Rights. I'm going to move to the next to Bill Turner. And Bill Turner is starting as the Privacy and Security Officer for Global Health in Oklahoma. And last but not least, my introduction to ONC was through Joy Pritts, who was the first Chief Privacy Officer at HHS. And we'll just kick off the panel. Bill has more of Benjamin has more of a patient focus, provider, physician focus, data integrity, and policy. Okay, go ahead, Benjamin.
Howdy, as she mentioned, my name is Ben West. I'm co-founder of the Night Scout project, which is a suite of open source software. It takes the readings from a continuous glucose monitor, makes that an internet-connected device. So we've been hearing a lot about internet-connected things. So this is an internet-connected medical device now. It's do-it-yourself, and it's become extremely popular. It's allowed people to get access to data that they would not ordinarily get access to, and we've seen a lot of side effects from that, including lots of sharing. So which is the topic of the day.
That's it? Okay. Most of my work is engineering, is technology policy and technology related. But in this panel, I'm going to blend that with the physician perspective. I don't practice medicine, but I do attend intensely medical society meetings involving privacy-related and IT-related issues for many years. And my input into this, the topic, is that Deanna Fay this morning very broadly, very forcefully put to us the scope of the issue of technology and how it's changing scope relative to employment, and just fundamentally touching patients as we collect all of this data and use it in a very complicated payment system and profit-based healthcare and all of this. We've heard a number of people talk about siloed healthcare system, the silos, research, clinical, and institutional silos. The topic of this panel is a different kind of siloing. It is the things that are very personal, the intimate wearables, which includes things like Fitbits, but also things that are, could kill you, like what Ben is involved with. And it includes the HIPAA health data, a lot of the legal focus here, and we saw and the limiting effect of just dealing with HIPAA and institutions. And on the other end, we heard a great keynote and a lot of talk about big data, which is not. So I just wanted to get you all sort of oriented on our perspective as both as a technologist and as a physician in the middle of that spectrum, because we're neither this patient nor we're the big data. We're somewhere in that HIPAA middle, and how that's going to work. So my simple introductory points are basically that the physician does have this role is in the middle layer as an intermediary across this intimate wearables and big data spectrum, across this uncertain regulatory and ethical spectrum that is so broad. And they are subject to a conflict of interest issue because, unlike lawyers and accountants, the physician is not working exclusively for the patient. And again, they are working for their employer. They're subject to population health measures. And we heard about earlier about all the tensions in terms of societal interests as opposed to the individual interests. And the patient's shame in not sharing their data, or and everything, things like that. So finally, I want to mention, I don't know if we'll get into it during the discussions, that I am involved, again, from the patient and physician perspective, in the technology to solve some of these consent problems and to solve some of these issues that I think Sandy Pentland did such an eloquent job of introducing some of the solutions and some of the potential outside of healthcare, and trying to get that in a group that Debbie and I work on called HEART, to apply some of that philosophy very broadly to healthcare. And I'll stop there.
You have 1 minute left. Very good.
I've played on both sides, privacy and security, and I focus a lot on integrity. And integrity in the security side is just basically moving data from point A to point B and making sure it's the same. In the privacy world, it's different. It's about context, use. Is the data that we're receiving good data? And when we talk about wearables, we basically have two types of wearables. We have that medical grade wearables that we get data from. Then we have these new wearables that are more consumer grade. And a lot of times we keep questioning the consumer grade. And sometimes we actually question medical grades. So there's a positive aspect of these wearables that you get into, and we can monitor patients at home, we can do better quality of life cares, but then we start talking about the intent of the data and where that data is going. We want to make sure that the users of the wearables understand where that data is moving and where it's going, and that they trust where that data is. A recent report by the Vent Research Group on empathetic, they actually put these wearables in 4 categories in kind of the history. The first was kind of sync me. And that's when you had a laptop and you take your wearable and you plug it in and your data was basically sunk up to your PC. Pretty private in general. You didn't have a lot of worry. We moved to see me, which is basically smartphones and the data that's going into the smartphones and being used with the smartphones. We're now at what's called Know Me, and that's basically using cloud technology. What the fourth step, and people are just starting to explore this, is actually Be Me. That's where you have implantables in your systems. All this is generating data, and we have to know if this data is actually, realistic. Is it good data? People are making decisions about it. We've moved from a point where it was very private, like a paper record, to a point that it's going to be very open, and how are we going to protect that data, and how are patients going to trust us in protecting that data. So, I think of systems right now, CPAP devices. They have SD cards. You take the CPAP device or the SD card out, you take it to your doctor. They can tell all sorts of information if you've been using the CPAP, what the pressures are. Are you sleeping more than 4 hours? Devices like that. That's entered into your record. On a lot of these wearables, we're actually producing the data and then we're taking it to our, physicians. I'm going to use my wife as a point. She was told she was pre-diabetic at one point. So she sat down with her iPhone and tracked all of her meals very diligently. I did it with her, but I wasn't as diligent. Then we went and saw a dietitian. We had 120 pages of information. The dietitian really didn't know what to do with that information. It was too much information for her. The only thing she came up with is you should use less salt, and that really doesn't help in a diabetic situation. So this is where we get into it, is that the integrity of this data, and especially the wearables. And, we've heard a lot today about profit in companies. And one of the things that was kind of interesting is that there's a trade-off in these wearables. The more sensors you have, the better battery, the cost, and the data processing makes these very expensive. And I'm going to pick on Apple for a second, really don't mind, but they have a $600 watch that does a lot of this stuff, which basically takes it out of the realm of a lot of people's, wanting to go out and buy a $600 watch to do something, that a Fitbit can do for $69. So you have this vulnerable society that is not going to be able to afford that type of technology and the use of that technology. So there's a balance and trade-off, and a private company has to make a profit. So how this is balanced is between sensors, battery life, of course cost, and the data processing aspects of it. The bottom line here is somebody is going to make a decision about your health based on this information. And you want that information to be as reliable as it can be so that they can make that decision, and you don't want it to get out in public in most cases. We hear about a lot of data breaches, and one of my concerns about data breaches is not necessarily the security aspects of the data breaches, but where all this data goes. So, we take the Anthem information, and then we take the adult friend finder that just got hacked, bring that together, you have a lot of information.
1 minute.
On an individual.
Hi. We've heard a lot today about how these sensors, wearables, may be very helpful, but also how there are some risks that are involved in using them. They're very helpful for consumers if they can actually get their information out of them. I think Ben has some information that he'll share more with us later about how it's not always so easy to get your own information in these circumstances. But the information is not only useful for consumers. Information is very valuable, and there are a lot of organizations that want to have this type of information so that they can make decisions. They have to make decisions looking at different people as to how they want to treat them, who they want to hire, what they want to do with them. And I think there's a lot of concern about how some of these wearables are going to be used. There is a report released within the last week or so by an organization called Tractica, which tracks wearables in particular. They predict that wearable device sales to enterprise and industrial customers will increase from about 160,000 in 2013 to 27.5 million in 2020. So the market for these devices is not directly to you as a consumer. It's to your employer or other industrial customers. You have to wonder exactly how that information is intended to be used. A key question here is how this information is regulated. And it's fairly complex, and I'm here to try to help simplify it just a little bit to the extent that you come away understanding that there are lots of gaps in how this information is protected, and this is something that we need to be aware of. And as somebody suggested earlier today, look forward 5 years and where you could be, and how we need to start acting now in order to make sure that we are in a good place, not a bad place. So one of the big questions is whether this wearable is protected by HIPAA. And some of them are, and some of them aren't. And a large part of it depends on how you get it. So if you have a device that is really medical grade, then, and it's prescribed by your doctor or other healthcare provider, that is they are undoubtedly going to be using that as part of your treatment, and it's quite likely that the information in that device will go to the doctor and will be protected by HIPAA. We had discussion earlier today about employee workplace. What do they call them? I'm sorry.
Wellness programs.
Wellness programs, that's it. The W, I had the wrong one. The employee wellness programs. And that's a gray area, and it depends on how those wellness programs run. employers are not directly covered by HIPAA. If you have a group health plan, which is run by an employer, the group health plan is covered by HIPAA, and they're supposed to have a divider between the information they have and that they share with the employer, the plan itself is. So information that is generated in that context by a group health plan or a third party on behalf of a group health plan is actually subject to HIPAA. If it's a third party that's doing the collection, health risk assessment, collecting data through that third party is operating as what they call a business associate, or kind of like an agent of the health plan. So that's also covered by HIPAA. Now, does that make life wonderful? No, but it does give you some protections. And it limits what they can do with that information without your authorization. What about employers themselves? Because I just touched on that a little bit about how the trend is to give the information for the devices to be offered directly through an employer, not wearing the magical group health plan hat. And HIPAA does not cover employers directly. People were mentioning earlier that if you get your device directly from your employer probably still owns it, and they have access to that data. Now, on the other hand, employers are covered by ADA and GINA. But we both heard earlier that both of those regulations and how they protect data are basically being scaled back to where employers will be able to ask you for your health data. And the consequence of your not participating in one of these wellness programs can be 30 or up to 50% of your premium. That's a lot of money for a lot of people. The consumer-facing wearables are not, although they're not subject to HIPAA or the ADA or GINA, are, depending on how they're offered again, probably subject to the FTC Section 5, which prevents unfair or deceptive acts or practices. And unlike HIPAA, the FTC Section 5 is, it's not prescriptive. It doesn't tell people what they can and can't do. It's more like, I hate to use the analogy, but it's more like pornography. They know it when they see it. And which has caused some issues for people who are trying to comply with it because they don't know exactly what the FTC is looking for. As a consequence of this, the White House, the administration, kind of recognizes that there's this growing gap of protection, and they've made a number of efforts up at the Hill to kind of plug some of these holes. But in the meantime, they've also encouraged the development of industry standards, and the NTIA, an office with the White House, engaged in a process last year for a notice of privacy practices with stakeholders to try to come up with some industry best practices for notice of privacy practices. Nobody adopted it. There was no consumer testing. There were lots of issues with it. So we are where we are right now is we're in a position where there are, little pieces of coverage here, little piece of coverage there. We thought there was protection here, but that's being scaled back. And we really do need people to step forward and think of these issues that are really growing rapidly and the policy implications for them. I would like to leave you just with one quick quote before I stop here and we go into the general discussion. Donna Shalala had a great quote from 1996, and I've used this repeatedly, and that was a lot of years ago, right now, 20 years ago, and it is still as valid today as it was then, which is, when all is said and done, will our healthcare information be used to heal us or reveal us?
That's good right then. Okay, so now we're going to start for the next 2 questions for that 7 minutes each. And the first question to the entire panel for a dialogue: do patients/consumers understand what they're authorizing and or giving consent to do?
Okay, I'll start. I think the answer is plainly no. They do not understand consent at almost any level. And no matter how many millions and millions of dollars we spent on the research side, for example, and I've spent 2 hours today listening to consent-related issues, I don't, from my perspective, sense any sense of progress whatsoever. The keynotes also, I think, brought that point as a minor point across. But my point is that authorization people do understand. They understand it because they understand how to monitor their bank account. They understand what happens when they connect an auto pay transaction to their credit card or to their bank. They understand every aspect of authorization. And whereas in the Internet at large, authorization technology has taken root, and we see it in social media connections to publishers and apps, certain apps doing it at a very large scale, such as when you connect your friends list to know which articles the New York Times wants to show you, your Facebook friends list, which articles the New York Times wants to show you on their home page. This kind of authorization and transparent control inside healthcare is completely non-existent, and where the technology clearly exists, and some of us are working on trying to move entirely from consent to authorization if possible.
Well, I have to tell you that I'm a little confused by the distinction that you're making right here. And I think most people in the audience would say, you know, if they sign something saying you could use it, permission, what's the difference if it's an authorization or a consent? Yeah. But, you know, rather than going there, I'd rather talk about, like, permission. Can we do that?
That's an interesting thing to talk about, I guess, the difference between consent and authorization. Well, but when it comes to, when you think about how am I authorizing a payment to go through, it's often very, very specific, very concrete, and so you know what you're giving permission to because it's very, very specific. Whereas when we give consent to medical data, often that it still seems very, very vague. It's very hard to get a sense of what that means.
I would not phrase the discussion in terms of authorization versus consent. I would just phrase it in terms of does a person understand when they're giving permission? And I agree with you that most of the time, individuals don't, when you go for one of these wearables, if you go to the website and you look what you're signing up for, you may have to read terms of service. You may have to read a privacy policy. You may have to then, actually click on something that says "I agree" somewhere along the way. And I would say that wearables are just one example of bad internet behavior for the most part, where individuals are just presented with a lot of information and don't really understand, because they're not going to read the 22 pages, what it is that they're agreeing to.
Joy, let me try a technical thing. The difference between authorization and consent is that consent is administered by the institution, whereas authorization typically is either administered by the institution in a very tightly regulated environment, as was mentioned by Sandy, telecoms and banks, or it is physically under your control, whether to share that particular blood glucose value or that activity level, because, again, as we heard earlier today, if that data is itself physically in your control, then there is no consent because it's yours. So when you get into the concept of ownership, there is no consent around data that you own, but there can be authorization around data that you own.
Yeah, I wonder if accountability ties into that as well, right? Because if you give permission, how do you maintain accountability without the concept of authorization? Right? Because authorization.
I don't want to really get into a philosophical argument or a discussion. I think when most people think of consent versus authorization, they have very specific meanings under HIPAA. Many people in the audience are familiar with those concepts under HIPAA, and we're not using them the same way. So I think that's a little confusing to people.
I agree with you. But what would you suggest then as how this technical distinction? How do we?
No, I think that the larger issue that what what we're getting at is that you think that if the individual actually has control over the information, if they, quote, have ownership rights in the information.
Control is the definition of privacy that we heard from the earlier keynote, the original definition of privacy being control.
Then that you would think that people understand if they own the information and they're saying, I give permission to X, I give permission to Y, that they usually understand because it's more limited rather than signing a large form that somebody else has written for them that says you can do all these different things and this is a legal document and now you're off the hook. Is that?
Yes, or to put it differently, and this again is work that Debbie and I worked on at HIMSS 15, if the consent or the authorization is presented in the context of the patient, if I get to set the format of those checkboxes, and not some institution today, and then Visa, Bank of America shows me one set of checkboxes, and Wells Fargo shows me their set of cell boxes. The way it happens in healthcare, everybody gets to present, whether it's for research or for clinical data, they present that form in their own format. So that, again, would be a corollary to what we're trying to say.
So are you working on standards for presenting consent?
Exactly. And Debbie should talk about that.
So I'm going to pause and say, at least in the technical, when we were arguing between what is consent and what is authorization, technically representative, it's another form of authorization from my point of view. But whatever is behind the scenes is different. But that is a very hot topic, and you can see between you to go. And I'm going to use this as an opportunity to segue to the second question. How do we reconcile the financial incentive for people to use this information against the patient versus using the information for the benefit of the patient?
You're on the payer side.
It's pretty, from my standpoint, when we look at financial information, we know what harm is caused. Everybody understands the harm associated. Something comes out of my checking account if it gets stolen. $50, $100, $100,000. In the medical, we don't understand what that information does to us at this point. We're making assumptions, but we don't have a lot of understanding. So, what is the financial impact of losing my health data? Right now, it's still back on the financial aspects of it. We see these databases stolen from the medical side, but they're used to file fraudulent IRS claims. We hear cases every once in a while about somebody going and getting care, and under another person's name or ID. But we don't hear a lot about that. And, under HIPAA, you don't have that personal right of action. In the financial side, you do. So, a lot of it is we're trying to figure out what the financial impact to the individual patient is at this point.
A lot of what I try to do in my medical society is to convince my my clinically practicing peers that it is in their interest to be the intermediary, to deal with the realities of this question of conflict of interest as I see it. They, as licensed professionals, are in a position to use their professional standing, their licensure, their liability to be sued in a way that takes this burden off of both the regulators on one side, because these laws are very difficult to manage, as I'm sure Joy is already is going to say more about that, and from the patient, where the consent issue, or whatever you want to call it, burdening the patient with these issues is, again, not necessarily a useful thing.
Adrian, can I ask you a question on that? Isn't there also some pressure on doctors to actually sell data? I mean, some of these EHRs, for example, the cloud-based ones, they present doctors with these contracts that say, we own your data now. So the doctors are kind of be put in a position where they're financially incentivized to release the data.
Well, it's worse than that. Doctors are now, because of the form of the payment reform, things are now subject to quality measures. And the quality measures that they're subject to are black boxes to them. So that's why I say that it's worse. It's not only that they're employed and or face population level liability. It's not that their employers are bad. It's that their employment contract is based on population level liability, but they also suffer from the fact that the quality measures themselves are not accessible to their profession. So the profession is supposed to be, by textbook, self-regulating, right? That's the definition of it's a group of people that regulate themselves.
We've talked about how the data that gets shared can generate a kind of a power for the people that hold it. So whether that's a financial institution or a government institution or a research institution or perhaps the patients themselves, right? And what you're suggesting, right, I think is not only is there can there be an asymmetry between the patient and the rest of the system, but the doctors are also subject to this asymmetry where they don't even understand the consequences perhaps of the information they're sharing.
Their compensation comes from two things, the population and the quality measures, right? And both of them are out of their control and are mandated.
So I don't know how much time we have left. I know we were running over a little bit before. We have about what? So we have 3 minutes. So we're helping you catch up, right? So we have about 3 minutes for anybody that has some questions.
So whether you call it authorization or consent, how does that even come into play as long as the HIPAA exemption for treatment, payment, and operation is still in force?
I'll start that first. My canvassing of people in the last year or so is that on almost every level that has to go. Whether it's academics, whether it's people that are interested in research, big data, in solving the actual problems, legislative action, in order to have the system scale to all the benefits that we've been hearing in terms of research, in terms of social goods, I don't see how that can stand.
Is that actually going to fall? What are the chances that Congress will rewrite that?
I find it highly unlikely in the near future because there has been so much pressure from the business community to actually make data sharing easier. I think you see this in the NPRM that came out of, here I am, alphabet soup, but the NPRM that came out of EEOC on the ADA. Boy, is that a Washington conversation or what? But when you look at it, the pressure that's coming from the business community right now is share the data broader. Go look at the 21st Century Care Act, where the provision that was passed out of committee actually makes research a healthcare operation, meaning that the way things are structured now, you either have to, as a healthcare, a covered entity under HIPAA, either has to have a patient authorization or go through an IRB in order to release information for research. They've just kind of gotten rid of all of that with this act that came out of this bill that came out of the committee recently. So I think the trend is unfortunately not in that direction.
You know, if you actually pay cash, it becomes an issue for an organization. Or to plenty of organizations that don't know how to handle the patient that pays cash and doesn't want it recorded, especially around the EHRs. What happens to that data? What happens to that information? It's a huge issue. So even if a patient does not want anything reported, it becomes a bigger issue for the organization of how to keep information on that patient. And the systems aren't designed today. It's designed for insurance. It's designed to capture all that data. If you pay cash, that shouldn't be captured.
Did you want to respond to the same?
Well, just to follow up on one thing, a friend of mine, a physician, signed up for EHR, her personal health record, and access to her electronic health record. And in small little type, she saw that it was a separate company that had the right to sell all of her data and keep it. So just a warning, that even though she thought it was part of her doctor and hospital, it wasn't, and they signed it all away.
Right, and she probably signed an authorization form. We found this when we were looking at some of these wellness programs that are run by health insurance plans, where they have you sign an authorization. And again, it's like you have to read 50 pages in order, and then nobody's going to do that to actually read the terms. But I'm a lawyer and I read it all. And the authorization form that you have for a service that either you sign up for or you get dinged on your insurance, you're authorizing them not only to collect your data, so to prove to your insurer that you're doing the right thing, but also so they can sell it. And so that's why, the HIPAA and the authorizations, it gives you a little bit of protection, but when people are using it that way, where they're trying to skirt the restrictions or do things that are not transparent to the individual, that's kind of a workaround, and it's something that people really, as you point out, really should be aware of. I always tell people, read what you sign, but you don't have enough time in the world to do that.
Well, one part you have to remember is if they want to change their privacy policy, they can't. So what they say they're not going to share today, they may be able to share tomorrow. And there's no protections around it.
I think the take-home message here is that if you have a technical means to gain ownership of your data, such as by signing in under a fake name when you have a service, or ordering certain services, signing up for your Fitbits as if you were signing up for pornography, then use those technical means, because if the law and the research community together don't get to the point of repealing this, of reversing this trend, then only technical means, such as what Ben is doing. Ben is not subject to this, and none of his project is subject to any of these problems. And I believe that this is really the future.
So on that point, I think it's time for us to wrap it up. Thank you very much for your